Hi everyone and welcome to our new exciting project here on our channel, the High Yield Questions and Answers interactive video series. Since we are done recording the most highly tested and high yield material on cardiology for the USMLE STEP exams, and all the videos we have you can find on our channel of course, this video will be a quick pace, high yield questions and answers video on cardiology. This is a video that will stimulate your thinking so we can avoid passive learning and test ourselves on what we remember from the cardiology subject. And because I mentioned passive learning, this is the worst thing ever, the worst thing that can happen to you. So what is passive learning? Basically, you listen or you read to some material and then you think, okay, I got this, I know this. But then you ask yourself a question, or someone else asks you a question, or the test itself asks you a question, and then you cannot provide the answer. So this is passive learning. You think you know it, but you don't really know it unless you read it again from the book or watch a video or some other material. So in order to avoid this, me personally, what I do is repetition, if necessary, every morning. And if I cannot provide an answer to the question I have asked myself within 5 or 10 seconds, depending on the question of course, then I need to repeat it more. On the USMLE STEP exams, there are many memorization questions, like antidotes and guidelines and side effects, you name it. You must memorize a ton. Where you shouldn't memorize though is when you're learning concepts. A strong base, a thorough understanding of a medical concept will get you places, not only during your tests but during your residency, and for that matter throughout your whole medical career. You want to be that person where everyone goes to ask the difficult questions. I also have two exciting news that I would like to share with you guys, but I'm gonna keep them for the end of the video so I don't distract you right now. So stick around until the end of the video. Happy studying and see you in a bit. Now for the cardiology concepts, you can check out our cardio videos that we have already uploaded on the channel. The questions we are going to discuss here are taken from those videos. Here I'm not going to go into very deep details, but we will just test our knowledge on certain super important cardiology facts that you must make sure you know before literally every USMLE STEP exam. They're universal, they're your cardiology Bible if you wish. And this is going to be video part 1. Because as I started making the slides, I realized there were so many important questions I wanted to make sure you guys know that I had to divide the video into parts so it's not too heavy and intimidating. Okay, and one more thing, I'm not saying that I have covered all high-yield cardio material in these videos, but what I will ask you here, you will be asked 100% on the STEP exams. I hope you find it useful. You can use it as a quick interactive review to test yourself when you feel like you're starting to forget stuff. And for your convenience, I will be reading out the questions and the answers, and you don't really need to watch the video if you're, for example, driving or walking somewhere or working out and you cannot physically sit and watch it. I will also be providing enough time for you to answer the question without the need of you actually pausing the video, so you can use it as a study tool on the go. Oh, and something super important. If you have the possibility, just say the answers out loud and as quick as you can. This is to train your brain to think fast on exam day, when you will need to dip into that knowledge very quickly and extract what you need to answer the questions. If you cannot say the answers out loud, of course, or you need more time, you can pause the video and take your time. And don't worry, the more you repeat, the connections in your brain will become stronger and stronger, and providing the right answers will become like a walk in the park. And this is the place you want to be, in that park, especially with a highly tested subject like cardiology. Are you ready? Let's get started. Question: how do you approach an EKG question? What are the 6 steps in reading an EKG? Answer: we have 6 steps in reading an EKG. Commit them to memory as you can see them on this slide, and you will never miss an EKG finding. Step 0 is actually not the real step, but you have to know that you always approach an EKG question by looking at lead 2. Step 1 is check the P waves, step 2 is check the PR interval, step 3 is check the QRS interval, step 4 check the QT interval, step 5 is check for ST changes, and step 6 is check for axis deviation. And here on this slide you can see my own EKG, and you look first at lead 2 because the net movement of the heart's impulses are headed towards the apex of the heart, which is lead 2. Lead 2 will give you the general view of the EKG. Okay, let's answer some important questions here about each step so we understand why the 6 steps approach is so good. Question: what does the P wave represent? Answer: the P wave represents the depolarization of the atria, and you need to examine all leads for P waves. The most common condition where you won't find P waves is AFib, as you can see here on this EKG. On the other hand, P waves may be present, but you might not be able to see them if they're buried within the QRS complex, as in AV nodal reentrant tachycardia as shown here. Question: describe a normal P wave. Answer: normal P wave is generally upright in leads 1, 2 and AVF, and negative in lead AVR, and the P wave does not exceed 3 small boxes on the EKG. Question: what is P-MITRALE and P-PULMONALE? Answer: P-MITRALE and P-PULMONALE are conditions that will change how the P wave looks. For example, P-MITRALE, as you can see here on the slide, has the characteristic notch or M-shaped form. Its length will exceed 3 small boxes and is seen in left atrial enlargement. Whereas the P-PULMONALE, as you can see here, is seen in right atrial enlargement and will present with a P wave amplitude more than 3 small boxes. Okay, important questions about step 2, the PR interval. Question: what does the PR interval represent and what is the normal duration? Answer: the PR interval represents the time that the impulse takes to reach the ventricles from the sinus node. It begins at the onset of the P wave and ends at the onset of the QRS complex, as you can see here on the slide. The normal duration of this interval is between 120 and 200 milliseconds, or between 3 and 5 small boxes respectively. Short PR intervals are suggestive of the famous Wolff-Parkinson-White syndrome, whereas PR interval longer than 1 big box, which consists of 5 small boxes, or in other words more than 200 milliseconds, is suggestive of AV blocks. Okay, important questions about step 3, the QRS interval. Question: what does the QRS represent and what is the normal duration? Answer: the QRS interval corresponds to the depolarization of the right and left ventricles. The normal QRS interval is less than 120 milliseconds or less than 3 small boxes. If the QRS interval is longer than 3 small boxes, then what you should do is look at the QRS in V1. Remember, the QRS in V1. If the QRS in V1 is upright, this means that you have diagnosed right bundle branch block. If the QRS in V1 is downright, then you have diagnosed left bundle branch block. That's easy, right? And you can see this on the slide here as well. And here you can also look for electrical alternans. This is very important. Basically, this is an alteration of the QRS complex amplitudes, and it is seen in large pericardial effusion. You can also look here for delta waves. A delta wave is an initial shallow upstroke before each QRS complex and is indicative of accessory pathway. On EKG, delta wave, wide QRS complex, and short PR interval is known as Wolff-Parkinson-White syndrome. Okay, important questions about step 4, the QT interval. Question: what is the QT interval and what is the normal duration? Answer: The QT interval reflects the time required for both depolarization, which is the QRS complex, and repolarization, which is the T wave of the ventricles. It is measured from the beginning of the QRS complex to the end of the T wave, as you can see here on this EKG. Here you want to check if the QT interval is prolonged or not. Quick way to determine if it's prolonged is if it's more than half the distance of the preceding RR interval. But it works only at normal heart rates, which is heart rate between 60 and 100 beats per minute. Also keep in mind that the QT can be shortened due to two main reasons. Can you think of them? One is mutations in cardiac ion channels genes, and the second one is hypocalcemia. Question: what is the QTC? What is normal QTC duration? Answer: normally the QT interval varies inversely with the heart rate. Therefore, we need to find a way to adjust it for the different heart rates. And how do we do that? Well, the EKG machine, as you can see here on my own EKG strip, gives you a corrected measurement, the so-called QTC, QT corrected. But the thing is that this value has to be confirmed, and the most commonly used rate correction formula was developed by Bazet, and I have shown you how to calculate it here. On the STEP exams though, they will give you the value of the QTC and they will ask you for the diagnosis or what you're gonna do next, and that's why you don't need to know how to calculate the Bazet formula, but you need to know the following values. QTC less than 440 milliseconds is normal for both genders. 440 milliseconds, normal for both genders. Now, more than 450 milliseconds in men and more than 470 milliseconds in women means long QT syndrome. So you need to evaluate the patient for any acquired or congenital condition causing this prolongation. Question: what are the congenital long QT syndromes? Answer: the most common autosomal dominant congenital syndrome is the Romano-Ward syndrome, and this syndrome affects purely the heart. Whereas the autosomal recessive form, the Jervell or Yervell and Lange-Nielsen syndrome, is associated with long QT syndrome plus sensory neural deafness from birth and has more malignant clinical course. Question: name some medications, diseases and electrolyte disturbances that you can think of that lead to acquired long QT syndrome. Answer: acquired long QT syndrome can be caused by three major groups of medications and conditions. Some of the most common medications that can cause QT prolongation are the class 3 antiarrhythmics, the amiodarone, the sotalol, the ibutylide, the dofetilide, as well as class 1 antiarrhythmics, the quinidine, procainamide, also the antipsychotics like thioridazine and ziprasidone, some antibiotics like fluoroquinolones and macrolides, antiemetics also like ondansetron and metoclopramide, the TCAs and SSRIs, some antifungals medications, and ranolazine, which is anti-anginal medication used in stable angina as a last resort drug after initial management fails. And also diuretics and many more other drugs can cause acquired long QT syndrome. Now, some of the diseases that can prolong the QT interval are heart failure, left ventricular hypertrophy, bradyarrhythmias, hypothyroidism, and hypothermia. And of course, the electrolyte disturbances, hypokalemia, hypomagnesemia most commonly, and hypocalcemia less commonly, also can cause acquired long QTC. Question: what is torsades 1? Answer: the famous torsades 1 is associated with long QT, polymorphic QRS, VTAC of 150 to 250 beats per minute, and sudden cardiac death. Torsades 1 in patients with acquired long QTC is most commonly triggered by premature ventricular beats. Torsades 1 has such a characteristic pattern that you won't miss it on the exams, and you can see here how it looks on the EKG strip. And remember, you treat it with IV magnesium sulfate, even if the patient has normal magnesium serum levels. Very important, and I'm sure you know it already, of course. And if this IV magnesium sulfate does not help, you can insert a temporary transvenous pacing, especially in the pulse-dependent long QTC. Okay, important questions about the step 5, the ST segment interval. Question: what does the ST segment represent? And the answer is, the ST segment occurs after ventricular depolarization has ended and before repolarization has begun. Super important questions. What are the STEMI criteria? Answer: these are the diagnostic criteria for STEMI. You need to have an ST elevation at the J point in 2 or more anatomically consecutive leads, and we'll see what they are in a bit. And this ST elevation has to be 1 mm or more in all leads except V2 and V3. In women, the ST elevation has to be more than 1.5 mm in V2 and V3. In men, 4 years or more, the ST elevation has to be more than 2 mm in V2 and V3. And in men which are less than 40 years of age, the ST elevation has to be more than 2.5 mm or more in V2 and V3. And what are the anatomically consecutive leads? They are the lead 1 and lead AVL, which are facing the lateral wall of the left ventricle. Leads 2, 3 and AVF, which are facing the inferior wall of the left ventricle, and any two of the precordial leads. Alright, so now we know the STEMI diagnostic criteria, and make sure you memorize it and just keep repeating it, because I can promise you that they will test you on these tiny little details here. And now, because we said J-wave, now we need to know what the J-wave is, right? Now, the J-wave is also called an Osborn wave or hypothermic wave. The J-waves are positive deflections occurring at the junction between the QRS complex and the ST segment, as you can see here. And they're most prominent in leads V2 to V5. And what makes them so important is that this elevation at the J point can mimic STEMI. So be aware of that, because J point elevation can be completely normal finding in asymptomatic patients. And now, apart from the J wave, you must know what is the Q wave, because you will see it all over the exams. Now, the ST changes in acute ischemia start with the T wave inversion, they progress to ST segment elevation or depression, and finally result in Q waves. Pathologic Q waves are greater in height than a third of the subsequent R wave. Remember that any process, acute or chronic, that leads to scarring of the cardiac tissue can result in Q waves. So that's it, now you know what is a Q wave. Now keep in mind that transient Q waves can also occur with myocardial ischemia, without infarction, just ischemia, and with certain metabolic disturbances such as hyperkalemia, as well as with the stress-induced Takotsubo cardiomyopathy. Q waves are also one of the reasons why we cannot perform a normal exercise stress test on a patient with symptoms suggestive of stable angina and previous history of STEMI. Because it's obvious, right? The presence of a Q wave can mislead us. In such case, what do? We do an exercise thallium or exercise echo stress test, but this we'll revise in a bit. Okay, important questions about the last step 6, the axis deviation. Question: what do we use the QRS axis deviation for? And can you fill out this table here that you're seeing on this slide with the corresponding arrows? Basically, to which direction is the QRS complex pointing in those 3 leads in normal, left, right, or extreme axis deviation? Answer. The axis deviation helps us determine if there is ventricular hypertrophy or not. The most efficient way to estimate the axis is the 3-lead analysis using leads 1, 2 and AVF. The normal axis has upright or positive QRS complexes in all 3 leads. That's easy. The left axis presents with QRS complexes positive in lead 1 but negative in lead 2 and AVF. And the most common causes here are left ventricular hypertrophy, left bundle, branch block, etc. If the QRS complexes are negative in lead 1 and positive in leads 2 and AVF, then the axis is rightward, which is a sign of right ventricular hypertrophy, pulmonary hypertension leading to right ventricular failure, right bundle branch block and others. An extreme axis deviation we observe in conditions like VTAC, hyperkalemia and severe right ventricular hypertrophy. And this is also very easy. On EKG, we will see negative QRS complexes in all 3 leads. Question: what do you use the voltage criteria for and what are the criteria? Answer: we use the voltage criteria as a quick bedside method to determine ventricular hypertrophy. So let's see how do we do that. For left ventricular hypertrophy, we can measure the S in V1 and the R in V5 and V6. And if the value is more than 35 millimeters, then we have diagnosed left ventricular hypertrophy. And we also have the Cornell criteria here, which is S in V3 plus R in AVL. And if the value is more than 28 millimeters for men and more than 20 millimeters for women, we have diagnosed again left ventricular hypertrophy. And for the right ventricular hypertrophy, we measure the R in V1. If the R in V1 is more than 7 millimeters for both genders, we have confirmed the right ventricular hypertrophy. Question: how does hypokalemia present on EKG? And while you're thinking about the answer, think of also the normal potassium values, the most common causes of hypokalemia, and how do you treat it? Answer: normal serum potassium is between 3.5 and 5 milliequivalents per liter. Now, what is hypokalemia? Well, hypokalemia is less than 3.5 milliequivalents per liter. And this hypokalemia will delay the ventricular repolarization, leading to reentrant arrhythmias. EKG might show T-wave flattening, U-waves, premature atrial and ventricular contractions, multifocal atrial tachycardia, ST segment depression, AV block and even cardiac arrest. One of the most tested reasons leading to hypokalemia is hypomagnesemia. So always check the magnesium levels in hypokalemia and keep the magnesium always above 1. Alright, and the leading reasons for hypomagnesemia is actually chronic alcohol consumption. Very high yield question across all steps. The treatment of hypokalemia is with potassium repletion. Question: how does hyperkalemia present on EKG? Also think of what do you do first when you see hyperkalemia and how do you treat it if you see EKG changes. Answer: alright, so hyperkalemia is potassium levels more than 5 milliequivalents per liter. And what do you do first when you are presented with hyperkalemia in a patient? The first thing you need to do is to repeat the blood work. If the elevation is confirmed, then you have to do an EKG on this patient. If you find EKG changes as the ones I have listed here, what you must do stat is give calcium gluconate. Why? So you can stabilize the cardiac cell membrane. And if they ask you how you can put the potassium back into the cell, the answer is peak bicarbonate or insulin plus glucose. Now the EKG changes here depending on the different concentrations of potassium are as follows. Potassium between 5.5 and 6.5 milliequivalents per liter will give you prolonged PR interval and peaked T waves on the EKG. Potassium levels between 6.5 and 8 milliequivalents per liter will present on EKG as loss of QRS complexes, ST elevation and ectopic beats, and if the potassium is more than 8 milliequivalents per liter, then you're gonna see sine waves, VFib and also asystole. Question: how does hypocalcemia present on EKG? And also think of when you notice hypocalcemia, which lab test do you check next? What is the calcium levels correction formula? And also what are the Kvostek or Chvostek and Trousseau signs? Answer: normal calcium serum levels are between 8.4 and 10.2 milligrams per deciliter. Hypocalcemia presents on EKG with long QT interval. When you see calcium levels less than 8.4 milligrams per deciliter, you must always correct them with the formula total calcium plus 0.8 times 4 minus albumin. If the corrected value is in the normal calcium reference range, which we said 8.4 to 10.2, then the reason for the hypocalcemia is hypoalbuminemia. Also, always check the magnesium levels here. Both hypocalcemia and hypokalemia will not correct if you don't correct the hypomagnesemia first. Hypocalcemia presents with neuromuscular irritability, so-called tetany. Here we observe the Chvostek and Trousseau signs. The Chvostek sign describes the twitching of the facial muscles in response to tapping over the area of the facial nerve on the face. Trousseau is the name of two distinct phenomena actually, both named after the French internist. Trousseau sign is a carpospasm elicited by placing a blood pressure cuff on the arm and inflating it slightly above the systolic pressure. The other phenomenon is the Trousseau syndrome of malignancy, aka migratory thrombophlebitis. And this thrombophlebitis is recurrent and it appears in different locations over time. It is most commonly seen with which cancer? Pancreatic cancer and also adenocarcinoma of the lung. Question: how does hypercalcemia present on EKG? Answer: hypercalcemia presents on EKG with short QT interval. Other manifestations include osteopenia and fractures, kidney stones, anorexia, constipation, weakness, psychiatric manifestations like altered mental status and fatigue. Alright, and if you're interested in the detailed EKG video, you can check that out as well. So how did you guys do? I'm sure you got all those questions right, but didn't you just love the challenge? I love making these videos, honestly. Thank you very much for watching, and since this is a new project, I would very much like to hear from you. Did you like this approach to high tested material, and if so, what did you like about it? And if you did not like it, tell me why. Any feedback is more than welcome, so we can make the next videos according to your needs and what works for you best. And as for the exciting news, this week was released the trailer of the new short film Aleppo. And why is this movie important for us doctors and medical students? Well, for two main reasons. Firstly, because it talks about the Syrian doctors and their experience in Aleppo. And secondly, because it was shot in New York and because we all know the executive producer of the movie. Okay, so I'll give you a clue. He is a USMLE legend. He is a best-selling USMLE author with the best-selling USMLE book Master the Boards. Well, we all know the name, right? It's Dr. Conrad Fisher. I'm sure that all of us have watched his amazing videos and have read his cream of the crop USMLE books Master the Boards, and you know that when he delivers the best. I watched the trailer, the movie is super promising, It's very exciting. Its premiere will be this month at the Bermuda International Film Festival and also in Annapolis. And I will drop the link to the trailer in the description below, and you gotta watch it. And for the second big news. Earlier this month, we were honored that Dr. Nicole Smith featured our channel, the USMLE Channel, on her website. The website is called www.familymedmom.com in her Featured Friday section. So there you can read the story of our team and the idea behind the creation of our channel. And I hope you like it. And I will drop the link in the description below, of course. And I would highly recommend, if you're interested, to follow the Family Med Mom Instagram page and her blog for very interesting and inspiring stories of her own, because she's a mom and she's in med school, and how she's handling the exams and family life. It's very, very inspiring and interesting. I'm a big fan of hers. And every Friday she's posting a new inspiring medical story, so you can go and check them out. And also, don't forget to make studying fun. Studying was never meant to be boring. If it's boring, it's never gonna stick in your head. And also, don't ever forget that not many have the courage and the strength and the discipline of doing what you're doing. All this studying, all this dedication, all these long hours, day and night to prepare for the USMLE. You should be proud of yourselves. And also, don't study just to pass a test. Study to save a life. See you soon.